Good morning to you all, and thank you, Chitra, to have asked me to participate in the course. I'm going to talk a little about flap creation in ICLs. It's a large topic, but I'll try to cover it up fast. You know, nowadays we create the flap either with a blade femto, and with the smile we don't have a flap anymore. So you have different issues coming up with each new technology. Now, originally we had a lot of patients complaining of glare, halos, starburst, poor night quality vision. But quite of this bit is a history. We have been doing LASIK since quite a few years now. With the aspheric profile coming up, quite of this is quite sorted. So let me show you a little bit about corneal wavefront guided, like what you talk about topo guided LASIK. Is this possible or not today? We all know that topo guided LASIK is possible. I use a Keratron Scout. And in the Keratron Scout, what is important is the total ocular wavefront. So if you have 100 aberrometry done, out of which 80% will come from the cornea, the rest is from the eye. So this is what actually statistically it is. So is this quite possible? It is. The advantage of using a corneal device is that we have best advantages that's not pupil dependent. So if you have a large ablation zone of 8.5, it's quite easy to do a topo guided LASIK. And another advantage is not dependent on accommodation, it's not dependent on your lens, and it's not dependent on the pupil size. So as I told you, that cornea is responsible for almost 80% of the aberration of the eye. Now let's take one example of a patient who underwent cornea grafting, and this is the pre-op. This is a pre-op corneal wavefront, and this is the ablation profile, and this is the post-op. So patient was operated for keratoplasty many years back, had a -4 with -5 at 6/12, and post-op is pretty good. So this is possible when you do a wavefront guided laser. Another interesting case, patient had poor night quality vision with a -0.75 spherical error, 6/6. So patient was quite okay, but poor night quality vision, you can again do a topo guided laser. This is the pre-op image, this is actually the profile, and this is the post-op corneal wavefront image. So the quality of the image we can ultimately not, sometimes you can even do a wavefront guided treatment and not treat the refractive error. Suppose the patient was 41, 42, you can leave a -0.75, just do a topo guided aberration, and that will remove the aberrations, and that is the advantage that we'll have. Now, as far as flap-related complications and laser complications and femto complications, so these are different issues which we have to handle. Now, I'm going to do a little video on how to deal with different flap complications. Okay, first is different flap complications related to LASIK, and this is all related to blade. Okay, one is a nasal decentered flap. I'll show 2-3 of them because of the time restraint, and epithelial ingrowth, inconsistent flap thickness, and flap wrinkles. So are we going to handle all of them, and do we need to interfere with all of them? See, this is day 1. Okay, a patient comes back, you have a flap folded inwards, you have to deal with this. So there is no controversy here. You just open the flap and just detach it. So you can see that what we are doing here is to take 2 sponges, 90 degrees to the whole flap, make sure that the sponges are dry, and this on the back surface of the stroma, and then put the flap back. When you put the flap back, you'll actually see the same line on day 1 on the table. Don't worry about this line, this disappears the next day. But you have to make sure all the epithelial cells are off, you've done this, and this is on day 1, nothing really happens, you have to treat this, and if you see the same patient next day, you can not see that line at all. So don't worry about it. If you see it on the table, don't panic, the next day you won't see it. Now we deal with the next case. This is a nasal hinge, and it's completely decentered inferiorly. Now when you see it the next day, what actually happens is the epithelium has grown all over here. Don't forget that. So you have to actually find the edge of your flap. So you have to deal with this. So as you can see, this is how the whole flap has moved downwards. It's a small nasal hinge. And I've got this back and put it back into position. And now got it back into the center. So all the area where the epithelium had grown has to be removed. And then invert the flap, and the rule remains the same. If the flap has a fold horizontally, 2 dry sponges 90 degrees to it or perpendicular to it, and move the 2 sponges and make sure that it is dried. And then once this is done, put it back, put the flap back. Now, question here is, do you need to remove the epithelium at the day one? Answer is no. I'll tell you when you need to remove the epithelium. Now, this is quite well post-op. You can see here, this white thing, that's an epithelial ingrowth. Now, when there are nests, which Dr. Chitra showed you, they normally do not progress. But an epithelial ingrowth like this, I'll show you how it looks on the back surface of the stroma and how it has to be peeled off. And it actually is like peeling off a layer from the back surface. So this is a small thing that you can see here. And when we evert it, now just see the back surface. You can see the back surface. And now when we lift the flap, just look at the back. Now that's the epithelium ingrowth which is there. Now when you look at the back surface, it's like a small thin layer. And you have to actually remove all the epithelial cells from the surface of the stroma, from the edge of the flap, and the black surface of the flap. And you'll see that this is a very, very important step, that you remove all the epithelial cells. And this does quite well. This is what you have to do on attempt 1. If you have regrowth or something, then I normally like to use mito in the second attempt. The first attempt I don't like to use. And you can see that whole thing is being, take a forceps and you can actually peel it off from the back surface of the stroma. You can see this, and that's coming off. So this is actually the growth which is happening there. It actually goes on the back surface. It goes till the margin of the flap or the edge of the flap, and it does quite well. So make sure that this is completely removed, and then you put the flap back, and you can see that it's completely removed till the end. And then you just have to put here, this is the last part, and then just put the flap back. So that's as far as epithelial ingrowth goes, and that's how it actually works. I'll show you one more case. You can see a little, it's not a buttonhole through and through, but in such cases you don't need to stop the laser. One can go ahead and apply the laser and everything is fine. It's really, because don't forget that the extra corneal tissue is on the back surface of the flap. So at this stage, not doing the laser doesn't make sense, and one can go ahead and can do that completely. Now, there's one more case where you will see multiple striae right in the center. Now, this is seen after a week. In such a case, we have to remove the epithelium, and I like to remove the epithelium from the central 6 millimeter. And if you remove the epithelium, don't forget you have 110 flap, 60-70 microns is off. So now we have only 50 microns remaining. But you have to go ahead and do this, and then only this is going to work. Because if you try to just lift the flap and not remove the epithelium, actually the microfolds or the folds are going to remain even later on. So the only way out here is to make sure that you remove the epithelium from the central area, and then be very, very careful, because your flap is only 50 to 60 microns thin. Then you evert the flap and make again the same action what you saw previously. Perpendicular, gently in the center, because here the cornea is very, very thin. You have the thickness here, and this is the folds which are going vertically. Again, go perpendicular to it with 2 dry sponges till the edge. If there are any epithelial cells, they are also removed. So this is how we handle a vertical fold right in the center. If it is seen 1 week later, put the flap back, and that's done. One more case I will show you, which is interesting, because watch this. RK done, LASIK done, and when we remove the contact lens the next day, it's torn. Can you see the whole flap? And this is the epithelium which is grown. This is the last case. We have 3 minutes to go. And you can see this is the epithelium, and this is the free part that is lying. So actually the flap tore from here to here. Why this really happened, I have no answer. But this is what I saw the next day. So we just removed the contact lens, and this is the epithelium which is grown here. And this has to be identified. The epithelium has to be removed from all that area. And now look at and I'll show you a post-op picture of the same, and you'll be surprised how good it looks even the next day. Now, question here is, do you need to mark? You really don't need to mark, because your RK marks are the same, which is going to help you. You can't put this flap upside down, because your RK marks are not going to match. So if you put this flap in the right direction, again the area which is torn, you can see that it's being arranged now, and then make it straight, and once it is done, put the flap aligned. So watch again these RK marks, the same RK marks which are actually aligned, and this is how the actual cut was. So this was the next post-op day. Again we go ahead, make sure this is aligned, and when I show you the alignment, you will see it's washed properly. We make sure it's aligned, and now watch these. This whole thing will help you to make sure you are straight. Normal fear in a free cap is the right side up or the right side down, and once we make sure that it's aligned, just make the back surface of the stroma clean the epithelium, the back surface of the stroma here, the black surface of the flap here, remove all the epithelium cells and make sure that the edge is everted and moved off, and then place it back. Now when this is done, these are your marks which actually have to be aligned when you put the flap which is torn back into position. So this is actually going to guide you whether you're placing the flap properly or not. And I'll show you the first. Once all this is done, we'll also see the other side being cleaned. Put the flap back. Once the flap is irrigated back into position, we dry it into position and then see this alignment. When you see the alignment, it goes ahead to the other side of the cornea, same way here. And this is perfectly aligned. Make sure that the edge is everted. I like to evert the edge of the epithelium here so that when it grows back, it actually gets back into position. Now let's look at this case the next day under the microscope. And this is how it looks actually the next day under the microscope. So this is the next day under the microscope. You can hardly see that cut edge, which was actually going through like this. And when we put the light on, you can make it aligns quite well. All these marks are quite well aligned. So how do we try to avoid this? Now as far as controversies in ICL is concerned, one is ideal vaulting should be this. A low vault means and chances of going to an anterior subcapsular cataract are high. A high vault is the other way around effect because grounding at the angle can cause iris shafting and pigment dispersion and glaucoma. Accurate sizing of the ICL is very important. Various ways of doing it. I have an op scan, or best is a caliper, which nowadays is better. You have a Simfluk imaging system, and add a 0.5 millimeter for myopes, subtract a 0.5 for hyperopes. Sulcal to sulcus, one other way out is to do it on the UBM, and of course to do a PI with the new ICLs in where you have a central hole, one does not need to do a PI, and an ICL exchange when and how. I did a IPCL produced by IOCare, minus 11 number. To my surprise, post-op was plus 9. Now there can happen mistakes only in 3 places. Either your refractive error, now we have a wavefront analyzers, we had minus 9 which is perfect, we had a spectacle reading which is perfect, the measurement is done by the company, the lens is produced by the company. So when I explanted the lens and send it back to the company, they said then the lens is correct. So they said do the refractive error checkup again post-op, and the patient was still minus 11. So the point here is the mistake can happen at any level, but we have to make sure in such a case you don't have a choice but to remove the ICL. So explanting a phakic IOL, now this is another phakic IOL, just a little small video, I won't take, I'll just show you how to do it. Now this is a varices, the patient had a cataract. You have to do it straight, it's very easy. There is a special varices forceps which is available. Watch this. You can see, hold the forceps, and once you hold the forceps, just take an iris repositor and remove the iris from the claw. It's a very simple step. The same thing is done. You can see the iris is engaged here. There's a cataract inside. I'm just showing a method of how to remove this. Again hold, put a viscoelastic above, and take the lens a little back, and there is a claw forceps. It's called a varices forceps, which actually helps you to hold the IOL. Again, the right hand holds the lens. The left hand gets an iris repositor, so you made 2 side stabs. This is a non-foldable lens, and the whole lens has to come out through a little larger incision. Any other ICLs or IPCLs can be folded, and it comes out through a 3.2, 3.5 millimeter incision. Now again hold this, you just come the posterior surface, go in with an iris repositor, just hold the lens, push the iris repositor down, it actually takes the iris off the claw. And it's as simple as that. 1 attempt, second, and it's completely gone. And you can see it's being detached completely and the claw is exposed completely out. So this is how, as far as explanting ICCL is concerned. How do we reduce, this is the last slide. One should know the photopic and the scotopic pupil in LASIK surgery. One should know offset in hyperopia. If you don't enter offsets in hyperopia, you're going to have an unhappy patient. I also do one additional step. I don't know how many. We have a wavefront analyzer. And you change the pupil diameter on the wavefront analyzer from 4 millimeter to 6 millimeter. If the refraction changes by 1.5 diopter and above, then you have to do an ocular wavefront guided treatment and not an aspheric treatment, because the patient is going to be unhappy in night quality vision. No decentered elements because we have 6-dimensional eye tracking. But if you have an XY eye tracking, you can have a decentered treatment. Because you are tracking the pupil, the treatment is taking place at the cornea. The cornea looks slightly down, the laser does not recognize this, and
Dr.
you may
Kumar,
have a slight
you have
decenter.
to conclude.
Yes. This is the last thin flaps for all, and most important care is take care of DLK. Thank you very much.